start, we've got an hour of the second webinar. Yo-Yo, I started recording this for those who are not able to make it. We've got a very much exciting agenda, so we would like to stick to time. What we've agreed to do is go through the two presentations from our two speakers, one after the other. Then we've got dedicated time to then have questions after that. So from 12:40 to about 12:55, we'll have some questions. But throughout the presentations, feel free to drop in any questions you wish there. My name is George Danyika. I'm a program manager from the Health Innovation Network, Northeast North Cumbria. In the chat, Yo-Yo has dropped in the agenda for those who would want to have a look at that. But the housekeeping are on the first slide there. Your microphones are muted. Do raise your hand if you want to speak. There's a contact email for Yo-Yo there. And we will definitely share the presentation of our speakers after this. On the next slide, please. Okay, so this is the agenda we have got today. I'll give a recap of the first webinar, which we had on the 2nd in July. Then I'll pass on to our new chair of the Heart Failure Working Group, Tom Green, just to give an introduction around his role, his work he's doing in heart failure and expectations going forward in the region for heart failure. Then we've got our two speakers, Ben and Nick. Then, like I've mentioned, we'll have some dedicated time to have some discussions, questions, and a chat around emerging themes there. It's really great to see that we had about 135 people who were booked onto this webinar. And I've also seen quite a breadth, although this is a regional webinar. I could see people from as far afield as west of England, Portsmouth. We've got Manchester, Huddersfield. We've got our industry colleagues on the call here. We've also got a lot of clinical staff, including retired GPs, members of the ICBs, NHS England, Department of Health. I can go on and on. So it's really quite diverse, the group itself. Like I've mentioned, feel free to use the chat. But we'll let our two presenters go through their presentations. Then we'll protect some time for a Q&A after that. Yo-Yo, could we go on to the next slide, please? So a quick recap here. We've lined up 3 webinars throughout the year until before Christmas. So the first webinar, we held it on the 3rd of July, which we focused on recognizing the signs and symptoms of heart failure. This was aimed at our healthcare professionals to recognize signs and symptoms of heart failure and specialist assessment and diagnosis of heart failure. The two speakers then was Jack Lyon and Professor Ahmed Ford. Most of you might be familiar with these two presenters. Today, though, we are focusing on how we work around raising awareness of heart failure. And we've got two great speakers here from two different schools of thought. Ben, who will be talking to us around CDRC searches or patient searches, and Dr. Nick, who will be focusing on campaigning on raising awareness of heart failure. And they all will be sharing their own experience within this space. So without no further ado, I will pass on to Tom Green, our chair for heart failure, the working group, who will just give you a bit of a background from his own clinical work area and the priorities for heart failure as we go along. Nick, Tom, over to you.
Thanks, Joe. Hi, everyone. My name's Tom Green. I'm a consultant cardiologist at Northumbria. I'm sure I know some of you from out and about. Obviously, my specialist interests include heart failure, and I run our virtual ward service here and have authored our heart failure guidelines as well. So I'm very pleased to get started with the network group, and hopefully looking forward to getting everyone involved with that and moving forward. The priorities really that we will be looking at, we have a meeting tomorrow to discuss this in a bit more detail, but the national priorities that we will be embracing are the early diagnosis of heart failure, so early access to NT-proBNP screening in the community, and then making sure that in secondary care we can get echo access, making sure that patients get on the 4 pillars, so that heart failure-induced ejection fraction patients are on all the relevant medications to reduce morbidity and mortality, looking at access to rehab across the different trusts in the region, so trying to ensure equal access to this, and lastly hospital at home as well. So I hope many of you will be able to come onto the meeting tomorrow and we'll be able to talk through these things in a bit more detail. Look forward to it. Thank you.
Thank you so much, Tom. And you could hear the invitation for next tomorrow's working group. For those who are interested, just drop me or your an email or a chat. We'll give you the link to join. I'll pass on to Ben, who will talk to you about patient searches.
Perfect. Thanks, Joe. Yo-Yo, I'm just going to take control of the screen if that's okay.
Yes, please.
Perfect, thank you. Hi everyone, and for those of you who don't know me, my name's Ben. I'm a program manager for CDRC. What I'm going to discuss today is a little bit of an overview of what CDRC is first and foremost, just for those of you who aren't aware, just give you that bit of context, and then the reports that we've developed as part of this project as well. So first of all, who are CDRC? So CDRC is a multi-organisation collaboration between the Health Innovation North East of Cumbria, CBC Health Federation, NEX and Cumbria Primus Informatics, and also the NENC ICB. We are a NENC ICB NHS-owned digital resource, and although we're based in the North East, we have national reach. So a lot of our resources are tailored towards the North East, but our resources can be used nationally. And it's worth noting that our resources are free at the point of use. There's no cost or contractual obligation to use any or all of our resources. And our resources hope to put you, the clinicians, back in control of patient care so that you can provide the appropriate care at the right time to improve patient outcomes. So on the screen here is our core team. As we are multi-organisation collaboration, we have quite a few team members. So I'd like to say this is our day-to-day team, and we all provide something different. So you may be familiar with Dr. Gareth Forbes. He is a GP in Ledgate Surgery. He's also the director of Derwentshire Health Federation, and he is one of the co-founders of CDRC. Some of you may also know Dr. Tom Zamoyski. I can see there's a member of staff from Prudhoe there, so he's a familiar face in Prudhoe. And Dr. Jonathan Harness, who is a GP in Gateshead. So in terms of the resources that we offer, in a nutshell, if it can be developed within the clinical systems, we develop it. So that's patient searches, clinical templates, referral forms, alerts. I've got visualizations and questionnaires on there. That is a functionality that's only available in System 1. When the new release of EMIS comes out, we're hoping that will bridge some gaps between the two systems, but at this moment in time, that functionality is not available within EMIS. And it's worth noting that all our resources are hazard reviewed by NEX. That just ensures that all our resources pull through the appropriate patients. So who are they for? So therefore, any admin or healthcare professional managing individual patients or patient cohorts in their practices. They can be used at practice level, PCN level, up to ICB level if you have the appropriate agreement rights in place. So some of the benefits I've already mentioned, they are free at the point of use. So there's no cost or contractual obligation to use any of our resources. There's flexible implementation. If you just want to use the reports that I'm going to show you today, perfect. But as I mentioned, there's a lot more other resources on there. So there's alerts, questionnaires, etc. that you can use, but it's completely up to what you're looking to use. And save time. So we develop these resources for you. For those of you who do develop within your practices, you know how much of a time burden it is. We're here to alleviate that burden from you. So looking at the CDRC approach, there's numerous ones on here. So there's opportunistic, routine care, and systematic targeting. And these fall into our 3 main areas of CDRC. So our screening, case finding, and management of your patients. So a few examples, I'm going to use CKD as an example on here, as that's a hot topic alongside heart failure at the moment. So an example of our opportunistic resources are our patient icons. So when you retrieve a patient record within System 1 and EMIS, you will get an icon in System 1, and on the right-hand side of EMIS, you'll get a little alert. This just highlights key information that you may have missed on the patient record. There's also real-time change. That's another alert on System 1, which can also be replicated within EMIS. And this is something that you cannot ignore. You either have to action it or physically close down that alert. One of the amazing things of System 1 is the dashboards, and this is CKD dashboard that we have. So this shows you the prevalence of CKD broken down into key stages, and further down we can see there's potentially missed CKD and patient lists on the right-hand side. Further information, you can click on the jigsaw piece, and that provides you those patient lists of those patients in the row. It's worth noting that this functionality, although it's solely available on System 1, all these are just tied to reports, so the reports are also available for use. So although it's presented nicely in System 1, you can just run the reports in EMIS and get the exact same data. And this just shows some further CKD reports of our monitoring requirements for CKD. So through using CDRC, there's been a Gateshead pilot project looking to improve the prevalence of CKD. And as we can see here, in just over a year, there's been an increase in CKD prevalence. Where was it? 13.2%, which is quite a big chunk of CKD patients. And there's been an increase of nearly 2,000 patients who have an updated EGFR. Furthermore, the pictures on the screen here just show the use of CDRC across Derwent-side PCN. So as part of their quasi scheme, they use CDRC resources to improve the prevalence and condition management of certain condition areas. So as you can see here, hypertension is significantly higher compared to the NHS average, and CKD is higher than the average. Yes, the prevalence is high to start with, but there's been an increase in trend of prevalence within that time period. So the heart failure reports. On the screen here are our quality improvement reports. These are available on System 1. They're available on the CDRC Quality Cardiovascular folder. There'll be multiple reports in this folder relating to hypertension, AF, and SGLT2s. So you have to scroll down, look for the heart failure section. And as you can see here, there's case finding reports. So these are patients who potentially should be diagnosed with heart failure but haven't been, so it's worth reviewing those patient records and updating their record accordingly, and those to consider for intervention treatments. We also have some prevalence data. So Sierra and Malik asked us to look for heart failure prevalence across the region, and also the heart failure alongside different long-term conditions across the region as well. So these are available on the CDRC Performance Cardiovascular folder. They'll be located near the bottom of this folder, as there's other reports available in here as well. And this is just to demonstrate the EMIS reports that we have on there. So all our EMIS reports are housed on the CDRC website. You can just go into the website, go into the cardiovascular section within the EMIS page, and then you can download these reports and import them into your folder, EMIS report, sorry. You don't have to get in touch with us to ask permission. You can download these reports free of charge and use them on your own free will. You'll see that they are date stamped. It's worth noting that when we do develop these reports, we upload them back onto the website with an up-to-date date stamp. So it's worth just cross-referencing what you have compared to what's on the website every so often. It'd be worthwhile joining the CDRC mailing list. There's a link to that on the CDRC website. And that just means you'll get information about if there's a new release of resources. So rather than using resources for a year down the line, we'll then let you know if new resources released. And that is me. If you have any questions about the reports or accessing or anything like that, please get in touch with me using that email address on the screen, or pop your questions in the chat box and I'll answer them as we go through the presentation. I believe there's time at the end as well that we'll be able to discuss this as well, but I'll do my best.
Thank you so much, Tom. And yes, pop your questions in, but we've got that time which is protected towards the end. So I'll pass on straight on to Nick, just go through the Beats Heart Failure campaign.
Yep, thank you, Joe. Great to be speaking at the event today at the webinar. Just going to take you through the Beat Heart Failure campaign. Next slide, please, Yo-Yo. Okay, so I thought I'd put a bit of a twist on it. Northern Soul, Beat HF, raising the awareness of heart failure. Next slide, please. So I think we all appreciate that heart failure is poorly understood, apart from outside of the specialist and patient communities. And what we need to do to help drive the conversation, improve outcomes, both economic, patient, and other outcomes. Next slide, please. So I'm just going to take you through a little bit about the Pumping Marvellous Foundation with the UK's heart failure charity, and a bit of a who, how, and what approach to who we are. Next slide, please. Okay, so I started the Pumping Marvellous Foundation way back in 2010 when I was diagnosed with heart failure. And what I found when I was diagnosed with heart failure was that the clinical support that I actually got was fantastic. But what I didn't get was the support that I needed as a person who was going to live with heart failure. So I started a small support group in East Lancashire, and it developed into this UK-based heart failure charity. We currently have offices based in Preston, but we work across the UK, both at a local, regional, national, and international level. And our focus is around helping people to live better with heart failure. Two key elements of what we do. I'll cover in a bit, but everything that we do is about patient-centric support. Everything that we develop and we do is around the need of patients, and we have large patient communities where we aggregate and we understand the insights that they give us into what it's like to live with heart failure. Next slide. So we collaborate right across the board. We have huge patient communities who we talk to on a daily basis. I think our largest community has nearly 1 million interactions a year on our Facebook group. We use Facebook because we can control it, and it's great at managing communities and groups of people. And we harvest the insights, and we work with the patients and take those insights into decision-making chambers, whether that be at NHSC or with Health Innovation Network or a local level ICBs, PCNs. And we take those experiences and we develop projects, and that ensures that patients have a point of discussion at the decision-making table. And it's not just my team and I, it's our patient educators who do this. So we have around 30 to 40 patient educators. We also have a clinical advisory board made up of about 14 or 15 what I would say is world-leading heart failure specialists, professors, consultant cardiologists, GPs of special interest, including Amit Fuat, who was noted just before, as well as sonographers, cardiac rehab experts, etc., etc. Next slide, please. So what we do, we provide patient education, various formats across the UK, 350,000 last year. Booklets were sent out to NHS teams, including predominantly heart failure teams, both in acute and community settings. We're increasingly seeing more of our booklets being sent out to primary care, health centre, GP settings, which is encouraging because that shows there's an appetite to help people live better with heart failure, and also to learn about heart failure as well, and what primary care could be doing to help with that point of living with heart failure. Peer-to-peer support, I've talked about the online communities, and we do one-to-one coaching and advice for those diagnosed with their carers and families, because it has a total impact across the family. We have patient educators, about 30 or 40 of them are experts. They feed into NHS England, Health Innovation Networks, NICE, and SMC in Scotland. And we provide leadership to the time to diagnosis and treatment conversation through our BEAT program. And BEAT stands for breathlessness, exhaustion, ankle swelling, time to speak to your GP or nurse, or time for a simple blood test. So we're relating that to the NT-proBNP assay. So BEAT is Beat Disease Awareness, Beat Heart Healthy Events, Beat Pharmacy, Beat to Treat, from Beat to Treat in 60 minutes. And we offer leadership position around what it's like to live with heart failure and some of the solutions which make patients and their carers' lives better. Next slide, please. So I'm just going to break these down. So BeatHF National Disease Awareness Campaign, that's the first component. We are going to be producing a playbook. It's just how much time I've got to actually develop that playbook, but we're probably, I reckon, about 2 weeks away from then distributing that across stakeholders to sort of educate you on what BEAT actually stands for. But here's a first glimpse. So BeatHS, a National Disease Awareness Campaign, and next slide, please. And the 4 pillars of the campaign are BEAT Symptom Tool and disease awareness. So using that BEAT symptom tool to help with the identification of heart failure. BEAT Heart Health Events, and we'll cover that in a bit. BEAT Pharmacy and BEAT to Treat is what we see as a paradigm shift, and there is significant interest in BEAT to Treat globally as well. Next slide, please. Okay, so a memorable acronym-driven disease awareness campaign. Next slide, please. So just give you an idea of some of the areas that we've been to raise the awareness of heart failure to the general public, but also put it on the radar of the whole of the NHS, not just the acute system, which historically has been very much the area of focus for heart failure. So as you can see here, we do National Rail. I wish I'd just blown up the Burger King one a little bit. We thought we were going to get sued, but we didn't. And that's in Leicester Square. So we've done it around a number of cities in the UK, including London. We also have, we've run huge national radio campaigns, particularly on chat shows like LBC and also Classic FM, because they're our target market. Next slide, please. So the BEAT Heart Health events, and these were designed to understand the prevalence and finding people early and show that you can go out to people rather than them coming to us and turning up at primary into primary care or turning up at A&E where they are highly symptomatic. It's about catching it before it becomes overly complicated. Next slide, please. So as you can see here, we have these BEAT Heart Health events, which we've run across the country in the 4 nations over the last 2 years. We've got Preston tomorrow, which is our hometown, and then next week we've got the West Midlands or the Black Country, I think it would be. Then a couple of weeks after that, we're back in Scotland, and we offer heart health events to the general public. We work with the whole system, so we work with PCNs, GPs, individual GP surgeries, PCNs, ICBs, the Health Innovation Network, and we drive the awareness of heart failure, and we offer free heart health checks to people. Those people can come in from social media. There's very much a walk-in. It's not really an appointment-based. We have run one appointment-based big heart health event where we saw around 500 people in Stoke-on-Trent, or Staffordshire actually, that was appointment-based, and they were all brought in on appointments. That's a significant amount of people in one day. The largest event that we've run was at Stoke City FC, where we had 957 people walk through the door, and probably the second one after that was Brighton, where we worked with the ICBs and the HIN and the local PCNs, and that brought in over 700 people. So we roughly get about 400 people on average, and we go to the people rather than the people come to us. We're finding significant levels of hypertension, around 33% hypertension, AF, and obviously heart failure. We have some papers which I'm willing to give Joe the links to Jack HF, where we published our results, and makes for very eye-opening experiences. Next slide, please. So Beat Pharmacy. Next slide. So all I can say is coming soon. We are due to create our first Beat Pharmacy in the next month or so. We've only just got the funding to do it, but we're asking ourselves the question, if we're checking for hypertension and AF within pharmacies, why shouldn't we have a point of care tested NT-proBNP machine and link that up with the primary care network where the pharmacy is based, and also with the heart failure team. So that will be trialing in Liverpool very soon, and I'd be more than welcome to come back and give you some further information about that when we've got more data. Next slide, please. And this is this for us is the biggie. So Beat to Treat is a paradigm shift. We see it as it could be one of the most significant shifts in how we treat heart failure this decade. As I said, there's real international and national from NHS England. I sit on the NHS England Expert Advisory Board. There's real interest in this when we start aggregating enough data. And as I've said, it's about find, diagnose and treat in 60 minutes, not 6 months. There is an area of the country in the UK where echo wait times after a positive NT-proBNP as a patient, outpatient, is 2 years. And we have to change that. I'm not saying that's the norm, but next slide. So it's really, what's the problem we need to solve? And it was what Joe was talking about, which is time to diagnosis and time to treat. And it shouldn't be as complex as it is, but it is, because we live in a very complex system. And what we've done is we've put a pathway together, and we currently have, we had our first Beat to Treat site open up last month, which I can talk about now. Next slide. So this is the pathway. I'm sure you're all taking screenshots of this. This has been implemented. It was implemented first with Everton in the community, where AstraZeneca came in and funded Everton in the community, which is Everton Football Club's charity, to put on a Beat breathlessness clinic, which was fed with breathless patients by the local PCN, and this became the basis of our Beat to Treat pathway, and the idea that we can actually find people, we can find people, we can diagnose them, and we can treat them within 60 minutes. And let me just give you a really important point here. This is a triage method. So all those that have a positive NT-proBNP and an echo AI that indicates heart failure will go on to get a full stack echo in a hospital environment. And I think that's really important to note that before we may go off on a tangent saying we're diagnosing patients just off this pathway. So we're working, the first clinic started in the east of England. We're working with an amazing consultant cardiologist called Rudy. He's the heart failure lead, working with the Health Innovation Network, the ICB, the PCN, and the Cardiovascular Network in the east of England. And we have our first Beat to Treat site. We've got our fourth clinic running today. It's based in a GP surgery as a GP hub. So it has a Beat to Treat clinic. There are 4/5 other GPs within that primary care network who will feed into this one clinic that has a GPSI and a practice nurse who's got a specialism in cardiology. The patient is referred, they turn up. The practice nurse checks obviously the bloods that have been taken, because it's a referral from a GP. checks for beat symptoms, and then offers an NT-proBNP point of care test, where if that is over 400, all patients over 400 will get a AI echo. We are using a GE scanner and US2AI software to interpret the scan, where the GPSI will interpret the scan, and if needed, the heart failure consultant can also access that scan information. And if it is indicated that person has HFrEF, HFpEF, or any type of heart failure, they will get a further full stack echo in an acute environment in hospital. I can't give you any further data on this because it's still very, very young and very fragile, but we are seeing some encouraging trends around finding heart failure. Also, just as a point, which is an addition to this, is that we are using the new AI stethoscope to identify murmurs. So we are throwing all the technology at this. It sits within what we would say is the Department of Health's drive to deal with long-term conditions in the community, heart failure being a huge one, because there are over 1 million people with heart failure in the UK, and many are undetected, undiagnosed. And we're also using, we're throwing the full gamut of technology to create a pathway that, although we say beat to treat in 60 minutes, the patients that have been through so far have been under 45 minutes, and their feedback has been phenomenal. So we are looking at this against standard of care, which is the Health Innovation Network is doing the commercial cost effectiveness modelling, and looking at the standard of care in terms of the clinical outputs, but also looking at using KCCQ, which is the Kansas City Cardiomyopathy Questionnaire, as a health questionnaire at baseline and 3 months. So we're very excited with this. We have another Beat to Treat clinic starting in Kilmarnock in Scotland, and then we have interest from other health innovation networks and approaches from consultant cardiologists to run Beat to Treat clinics across the country. So next slide. I think that's it. So think beat. Thank you very much.
Oh, yeah. Thank you so much. I was trying to unmute myself there. Thank you so much, Nick. Really, really powerful stuff coming from a charity and examples of where this has started in England. And I know a lot of our colleagues on the line here at some point in time would have worked with your charity or heard of what you're doing. For me, just a quick recap here from the presentation that Ben has done. I think the takeaway message there is around joining the mailing list for CDIC, and you can see some of the developments or some of the new resources that have been developed there. Directly in relation to heart failure, I know Ben has mentioned the work areas that this resource has been used in, but regionally, working with Tom and other colleagues in the ICB, we are working on having a pilot around CDRC or case finding. We do know that optimization of treatment, as Nick was alluding to there, is quite important. But we also agree that for all the conditions, CVD included, finding the patients in the first place is just as important. So I think that's quite important. We're looking for pilot sites within the region for doing the searches. Coming on to what Nick has mentioned there, I'm sure we're all aware with some of the conditions like stroke, for example. There's in mainstream media advertisements or awareness raising campaigns around different conditions. But to us, beat heart failure, this is the big awareness campaign that we all working with. I know my colleagues in other areas and nationally from the Health Innovation Network have collaborated with Pumping Marvelous, and clearly I can see some questions which are coming from some colleagues there. So going on to the questions here, I've just summed up these 3 questions which I've seen in the chat, and we're still lucky that Tom Green is still on the call there, and obviously there's other clinicians on board. But Tom, there's one first question which came from, I think, Mohammed Javid, talking about what is your view around the diabetic patients who have got comorbidities, but they do not have exertional symptoms, so to say. What is your view in them getting identified in the first place and dealing with those patients? Mohammed, is there anything you wanted to add to that question? Feel free to answer that, Tom, if maybe Mohammed is still.
Yeah, thank you. It's a very interesting question. I must admit, I've not seen that recommendation from the Americans. So, saying if in older patients with diabetes who are asymptomatic, should we be screening with an annual BMP? I think that's really difficult, to be honest. I mean, heart failure is a syndrome, and so the part of the diagnosis is based on the symptoms. So in those patients who are symptomatic, there has been over the last few years this vogue towards kind of preclinical heart failure, which is tricky and debatable. We also know that in older patients, the cutoff for BMP, and particularly NT-proBNP, which we tend to use here, changes and is more complicated with age, sex, hypertension, atrial fibrillation, etc. My gut feeling is that we probably shouldn't be doing it because I don't know what we would necessarily do with the results and the cost implications. I suspect and I don't have anything to back this up, but I suspect that it's probably the benefit in asymptomatic patients, older asymptomatic patients, is going to be lower, and therefore I would guess it wouldn't justify the costs of the screening. However, if they are symptomatic, then absolutely we should have a very low threshold for checking it and moving on for checking an echo.
Thank you very much, Tom. I could see maybe Mohammed is not in a place where he could verbalize, but I think he's also gone on to respond to that. I'll go to a question for you, Nick. Then we can come back again to a clinical question here. I think there's a question from Mark Dodd, asking around. No, there was one question which was talking about is Beat Heart Failure as a charity and support available in Wales? I know you've mentioned, Nick, the work
Absolutely.
that you're doing in Scotland.
Absolutely, yeah. Northern Ireland, Wales, England, Scotland.
Excellent. There you go. The next question from Mark was around, I think you did mention, Nick, to an extent that there's a big wait time for echo for other patients. But Mark was asking that varied inequity of access for echo, does it challenge the need for early diagnosis, Tom? Oh, sorry, you're not.
Sorry, say that again.
Yeah. I think his question there, I've just summed it up. He's saying he recognizes the varied inequity of access to echo, but how does that challenge the need for early diagnosis? So if people are not getting the timely echo, how does that really challenge our early diagnosis push?
Oh, it's a huge challenge, and it's a massive problem. One of the things we want to look at within our network is to assess what the gaps in performance, I suppose, are across the different trusts within the region. But as Nick said, nationally there's huge disparity in access to echo, and we know that this is serious. We know that it's undiagnosed. We know what the mortality rates are, the worst in a lot of cancers. So it is absolutely vital that we try to improve access to echo services, and it's going to be something that certainly we want to look at regionally, but it is a major problem nationally, and it just doesn't carry the same kind of weight or funding that kind of cancer diagnosis and things like that have with the 2-week waits, whereas I think it probably really should do.
No, that's quite helpful, and I know I'm working with the ICB, Jack Lyon from the ICB, and one thing after our first meeting, Tom, tomorrow for the heart failure working group, we do have a survey which is going out to our clinical members, and I'm not preempting what is going in the survey, but we do know that wait times for echoes and the challenges involved is one area that we really need to get a picture of. So yeah, thank you for that response, Nick.
Yeah, I think this is the one thing I didn't mention with the Beat Street pathway, which is absolutely crucial actually, was that after they've been confirmed by the GPSI for a referral to echo, we treat them with appropriate GDMT, guideline directed medical therapy. So that's the treat element, which I actually missed out, which is a bit crazy. But I think, the biggest problem has pre-COVID and post-COVID has been finding people, diagnosing people, and reducing that time to diagnosis. And I haven't seen any real advancements in that. We are still having the conversations that we were having in 2015 around echo wait times. The one of the challenges was getting NT-proBNP more proliferation in primary care. The heart failure audit last year showed that there was a 10% increase in the use of NT-proBNP, which is a real positive movement, because heart failure is too big for the specialists to deal with by themselves these days. Primary care needs to help with the diagnosis, and then at the other end, once they've been through the hospital system and the NDT and they've been discharged back to primary care, is the medicines management aspect and trying to reduce those exacerbations that may or may not exist with patients. So Beat Street is a solution that hits all the right notes. We are treading carefully with it. The Beat Street pathway is sort of delivered with the charity and 5 or 6 of our Beat team, who are all consultant cardiologists and X, Y, and Z. But until we find some better way of doing it, I just don't think we're going to change. We're going to change the issue of echo wait times. And the benefit of Beat Street is not only the patients who get extremely anxious when they don't know what they've got, and that's a big issue in terms of their mental health, but also it improves their quality of life because we get them on guideline directed medical therapy sooner. It has positive impacts or reduction impacts on the wait times because as I said, it's a triaging point. So we're only giving the sonographers in the echo departments people they really need to see. And it also has, with the treatment angle, what we're trying to do is reduce the decompensating heart failure that has such a massive impact on the finances of the NHS. So, they're the sort of points that I want to get across, really.
Thank you very much, Nick. There's a couple of questions coming your way again, Nick, but there was also really positive feedback in the chat around the work that you've presented there, and Ben. So one of the other questions from Mohammed is around technology, and I know the work I'm doing with the ICB is reviewing the 6 cardiac rehab technologies that are coming on, because rehab is another area which we need to focus on. But the question really to you was around AI stethoscopes, that technology you mentioned. The question is that, is it also available in general practice, or is it likely to be available soon?
Is that for me?
Yes, the AI stethoscopes you mentioned.
Well, we've only just put it into our pathway, and we put it into our pathway because of what was the press release at the ESC, and the feedback from the practice nurse and the GPSI and the heart failure consultant cardiologist around the value of having an AI stethoscope around heart valves and murmurs. So we put it in. It costs about 450 quid from Amazon, but it's very much a valuable, we would say in the Beat Street pathway, it's very much a valuable addition. So whether it's available across primary care, I don't know at that price. I would have thought not, but certainly in our Beat Street clinics, I think they have AI helps people who, who aren't as maybe upskilled as maybe those who don't use AI. So this is about demonstrating that technology can leverage opportunity and improve health outcomes. So I don't think I've answered the question, but it would be good, wouldn't it?
It would be. No, thank you. Again, there's a few more questions, Nick, to you there. There's one from Wendy, I think, which has been supported by a few people there. Look at Wendy's asking if there are any plans for you to be holding some of your events in North Cumbria, purely because there's a high population or incidence of heart failure, HFF, that's that part of the world.
Okay, so we are looking for anywhere between 10 to 20 pilot sites, and I think we will be working closely with Joe and the team at Health Innovation North of England, Northeast, because Joe and team are believers in what we're trying to do. We just need to work out the mechanics, and we need some funding as well. So I would very happily come to North Cumbria. We are going to work with the West Coast, so South Cumbria, Lancashire, Cheshire, Merseyside. We've identified some sites there, which we will, if we can get the funding, we will do. So North Cumbria is an obvious one, and then Northumberland, Newcastle, and then going south towards North Yorkshire.
Thank you for that. And I know with Mark Henderson in our NENC team, we've got this industry working group, which is wider than just the clinicians and the charities. We've got our pharma colleagues there. So we are involving a wide range of partners in this program. And this answers to probably Imogen's question, which to an extent was asking about your AI technologies, but I think the core of the question was around how do we identify, or how would you help us, Nick, to identify potential funding to address those challenges, to roll out technology. So I think clearly, like you've said, there is space for us to get funding in the region, which can then support all our promotional programs there. Do feel free to unmute if you've got a question or raise your hand. I can see there's a comment from Mark there. The need for investment. Yeah, they're talking about investment there. We've got colleagues from our ICB, and I'm not trying to put Jack on the spot here, but do feel free, Jack, just to for us to talk through what we are collaborating with the ICB. But I know, Nick, you've got your hand up again.
Just to answer Imogen's question, sorry, I just unraised my hand. We see this as so it's a funding challenge at the moment because it's very, very new and it's inventive what we're doing, but we're not doing anything different what the NICE guidelines are suggesting. We're just gluing them together to make it faster. And I think that the sort of beat to treat thought process is very much around addressing equitable access to echo, which is important. So it is very much in the back of our mind that this technology. So we're looking at the Isle of Arran as a challenge for heart failure. And how do these remote communities? How does AI echo and point of care NT-proBNP testing and AI driven stethoscopes? How does it improve the access and equity of access to what we're talking about? So it's very much there. And also Mark's comment about echo is a key area to level up. So my comments are that in 2015 we were having conversations about resource planning, about more sonographers around, and we still need to do that. But just like it's very similar to heart failure. So I would say a number of years ago, when I was sort of starting off the charity, it was very much a specialist focus, and the problems become so big that there aren't enough specialists. But we need to work with primary care to help them feed the people in so that the specialists can do their bit and help them live better with heart failure. And it's very, very similar to the acute and primary care conversation where, primary care is so big. And if we can just infuse and enable primary care and help them to be, really good at the diagnosis aspect of heart failure so we can get them into the system. And, as I said, whatever happens in the acute, happens in the acute. The MDT then discharges that patient back into primary care. The patient feels that they are under control and the system is under control. And we can help with the medicines management. And, we're doing some stuff with Health Innovation Yorkshire, where we will be upskilling primary care nurses who see people on a regular basis in terms of helping them, the medicines management, talking and working with GP pharmacists around medicines management. There's loads of things that we can do. Anyway, I'm blabbing on.
No. I think it is quite relevant what you're saying, Nick. And again, there's many colleagues in the chat there, Louise, Erin, who are all asking about collaborating with you. Some in Barnsley is asking if you go down south. So we're not parochial about heart failure and this webinar in our region, because we know the challenges which we face here as faced nationally. So any collaboration is most welcome. We are being invited to the Yorkshire and Humber event next month around the Heart Failure Academy, which I know, Nick, you're also invited to, or you're part of as well. So that's quite very helpful. What I will suggest, Nick has put his email address there for anyone who would want to collaborate. We will be summing up in a couple of minutes the event. What we'll really like to ask all of you or any of you is to put in the chat areas that you would want us to be discussing in our third and final webinar of this calendar year, or this side of Christmas anyway. Possibly we'll hold that towards the end of November. So feel free if there is any work areas that you would want us to focus on heart failure. But at the same time, Yo-Yo and Tom and I we'll go through the chat. If you also are happy to put any challenges that you're facing clinically or operationally for heart failure in your region, you don't have to specify what region it is, but any common themes that come up, we are more than happy to try and address them. We've only got 5 minutes left. I don't see any hands up. I don't see any other extra questions there. I'll pass on to you, Tom, just to your own quick summary before I sum up for the end of the webinar, please.
No, thank you. And thank you to both the speakers today. That's been fantastic and really good to have a bit of discussion and questions from the audience as well. What I'd say is, yeah, please ask us anything you want. And as Joe said, yeah, if there's any particular things that we should be looking at, any suggestions are welcome. And just a final invite to say, please come along to the meeting tomorrow if you can. We'd be delighted to have as many people as possible.
Thanks so much, Tom. We are 4 minutes ahead of our agenda. I'm very grateful the number of people that have come online. Yo-Yo will be able to share the PDF of these 2 slides and presentation. And as Tom mentioned, if you're interested, please text or email us, Yo-Yo and myself. Then we'll forward this to our ICB lead, who will then put you onto the distribution list so that you don't miss out on any information. But yeah, thank you very much for this time. We will be sharing the agenda and time of the next webinar, which we anticipate it will be no later than the end of November. But thank you very much for your time, and thank you to our speakers. Bye, everyone.